run through those really quick. First question is, flat head bed beneficial in all patients with small vessel occlusions?
So, going back to future research questions. So we don't know. The question is are patients with other types of strokes, small vessel occlusions, etc., how much benefit do they derive? We don't know. But I think just as C. Miller Fisher said in 1958, it's probably a good idea. If you're getting a 20% free additional blood flow by head of bed flat, and the pathophysiology is somebody that had a blockage in their brain of blood flow causing damage, it just makes sense. You probably want to leave head of bed flat.
Yeah, the interesting thing about perforator strokes is that sometimes you think it's a perforator and you find out it's an elbow that is laying over the perforators. So I would agree with you that you just don't really know for sure. Now that we're doing CTAs on pretty much everybody, it's a little bit clearer. But we did early on actually look at small vessel strokes, and they don't respond like a large vessel occlusion does. These elbow cases, I always tell our nursing staff, one of the hallmarks of an acute elbow is clinical fluctuation early into the presentation. You sit them up, they deteriorate, you lay them down, they tend to do better. And it's subtle changes. You have to be a really good assessor of these patients to pick these things up. Where HEDPO's really screwed up is they never assessed the patient. So they just literally sat them into a position and then said, we'll look at you in 3 months. Well, that's kind of insane. The rationale for that Craig Anderson gave me was that nurses can't do a valid NIH stroke scale, which of course that's not a good thing to say to me. But it was really a very poor design. And then what he called an elbow, we don't really know if it was an elbow because they didn't do CTAs on patients. They just looked at an NIH and said, if the NIH is high, we assume it's an elbow. Well, maybe, maybe not. So, it's a good question. It probably, now that we've got CTAs on everyone, can be studied better. But it's not going to hurt them to lay them flat.
Next question, is there risk or incidence of a hemorrhagic conversion with head of bed flat and permissive hypertension, or with giving post-stroke meds like aspirin?
Great question. So, if anything, so interesting, I was just reviewing some data, and this is actually coming from the COMPASS trial, that patients actually with anticoagulation actually had less hemorrhagic, so the stronger the anticoagulant, they actually had less hemorrhagic hydration. There's a lot of factors that play into that, as far as how much time has passed before that vessel has recanalized, or if it has recanalized or not. So it really depends on how much ischemic tissue injury is there. And we weigh our anticoagulants, whether aspirin, Eliquis, it's on a patient. We're very aggressive, especially if somebody has, for example, atrial fibrillation. If somebody has no hemorrhagic transformation, just small infarction, we may restart or start for the first time anticoagulation that same moment. We may delay. Again, it depends patient to patient. As far as head of bed flat versus up, it again depends on what they've been given and how much time has passed and how much ischemic tissue. So it's really on an individualized basis on what that risk would be.
Thank you. Is there any research, either published or ongoing, looking at whether Trendelenburg position might be superior to head of bed flat position?
So those authors, you did see that they did mention Trendelenburg, and yes, there is research suggesting that Trendelenburg may be even more advantageous. Now, of course, we do that on a patient-by-patient basis here, but you're also weighing against some people that have an EF of 20-30% and different cardiac factors, and so you have to weigh it on a patient-by-patient basis. But yes, the logic would reason the more upside down you put an individual, right, the greater the blood flow. But that, if you think head of bed flat is difficult to tolerate, that's an even more difficult intervention to tolerate. And so that's on a very case-by-case basis. But yes, even the authors in the studies I talked about did reference an improvement with Trendelenburg.
Yeah, I just wanted to throw in, there's an Italian trial that's called Downsuite that's underway. There are some design issues with it that I don't like, because they're trying to group 30-degree and 0-degree together as the control group against Trendelenburg. They're gonna do the thrombectomy in Trendelenburg in the group that randomizes into that position. And then the others they'll do at 0-degree. But I think they're muddying the water, and I've given them that feedback. I would have rather seen them compare 30 to 0 to Trendelenburg, because that way we'd know, is Trendelenburg superior to 0? We know it's gonna be superior to 30, but they're muddying the water, and I think it's an important thing to find out because of exactly what Ray said. How many people are gonna tolerate hanging upside down that long? Because they wanna keep them like that for a pretty long period of time. And I just don't think that that's well tolerated. They're also not really looking at tolerability as part of their feasibility, which I think is a big mistake. If you were to ask patients, hey, how you doing hanging upside down? I mean, how many people are gonna be, yeah, it's great. I just think that that's a hugely problematic design.
Of note, Seymour Fisher said if you had basal occlusion, hang them upside down. So next time we discuss that, he will start with Seymour Fisher again.
Perfect. I think we have time for one more question here, and so I apologize that we won't get to all of the questions, but we'll try to keep track of these and maybe pass them along and try to answer them afterward. It's kind of similar to what was just being talked about. Is there future research or research that's ongoing about intubated patients with LVOs, and do they have an increase in pneumonia with the head of bed at 0 or below?
I'll let the Alexandros. I'm unaware of one specifically with intubated patients, but.
Yeah, again, down suites including them, so we'll find out from there. Technically, if you're hanging upside down, you'd think there'd be less drainage into your lungs, who knows? In Zodiac, we had intubated patients, and they were kept flat. If you randomized into the 0-degree group and were intubated electively for your thrombectomy, you were kept at 0 degrees. And a lot of people have said, oh my God, you can't do that. If you intubate, you have to automatically sit them up. Well, think about it. Are they gonna have their thrombectomy sitting up intubated? No, they're gonna have it at 0 degrees. When we do neurosurgery, how are those patients positioned? They're positioned at 0 degrees, right? So we did not see any problems at all with pneumonia, but our intervention was a shorter period of time. So I don't know, that's a good question, and we'll have to see what happens.
All right, thank you guys, appreciate it.
Thank you.